Hello, welcome to Pediatric Pulse. Today we are diving in a topic in pediatric care on refractory anaphylaxis. Anaphylaxis is a severe, potentially life-threatening allergic reaction that can escalate rapidly. While most cases will respond to initial treatment, some do not. This is what we call refractory anaphylaxis, a condition where symptoms persist despite appropriate medical intervention. In refractory anaphylaxis, there is no improvement in respiratory and cardiovascular symptoms. For respiratory symptoms, we have stridor and shortness of breath. For cardiovascular, you'll have a tachycardia and hypotension, despite administering 2 doses of IM adrenaline. At this point, establish a dedicated peripheral intravenous or intraosseous access ready to start your IV bolus fluids as well as required medications. Start by giving rapid fluid bolus of 0.9% sodium chloride. In pediatrics, we give a fluid bolus of 10 ml per kg. This can be repeated as needed to maintain cardiovascular stability and to address persistent hypotension. Give IM adrenaline every 5 minutes until the infusion has been started. Remember, the dose of IM adrenaline in anaphylaxis is age-based. IV bolus of adrenaline is not recommended, but may be appropriate in some specialist settings, for example in perioperative when an infusion is being set up. Give high-flow oxygen and titrate to an SpO2 of 94 to 98%. Monitor vital signs such as heart rate, blood pressure, pulse oximetry, and ECG for cardiac arrhythmias. Take a blood sample for mast cell tryptase. So the mast cell tryptase blood test measures the level of tryptase, an enzyme released by the mast cells, which are part of the immune system. This test is particularly useful in diagnosing and managing conditions related to mast cell activation, for example, anaphylaxis. So for interpretation, elevated tryptase levels can indicate mast cell activation. For example, in anaphylaxis, tryptase levels peak about 1 to 2 hours after the onset of symptoms and decline over the next 3 to 6 hours. Seek expert power early, as this patient might need ventilatory and inotropic support. At this point, you also need critical care support, which is essential to that patient. Start adrenaline infusion. This is because adrenaline is essential for treating all aspects of anaphylaxis. Follow a local protocol or start peripheral low-dose IV adrenaline infusion. Use the 1 milligram is to 1 ml adrenaline, which is also known as 1 is to 1000 adrenaline, then add it into 100 ml of 0.9% sodium chloride. Prime and connect the infusion pump via a dedicated line. Do not piggyback onto another infusion line. Do not infuse on the same side as a BP cuff, as this will interfere with the infusion and the risk of extravasation. Hope you can appreciate a diagram of an infusion pump as well as an extravasation site. In both adults and children, start your adrenaline infusion at 0.5 to 1 ml per kg per hour, then titrate according to clinical response. Continuous monitoring and observation is mandatory. High BP is likely to indicate adrenaline overdose. Titrate accordingly. Continue with adrenaline infusion, treat ABC symptoms, and titrate your adrenaline infusion according to clinical response. Intravenous adrenaline for anaphylaxis to be given by only experienced specialists, and also to be administered in an appropriate setting like theater, as you wait for an infusion to be set. So for airway, in case of partial upper airway obstruction with stridor, nebulize with adrenaline 5 mL of 1 milligram per ml adrenaline. And for total upper airway obstruction, follow the difficult airway algorithm with expert help needed. For breathing, oxygenation is more important than intubation. If the patient is apneic, bag mask ventilation should be done as you consider tracheal intubation. For severe and persistent bronchospasms, start by nebulizing with salbutamol and ipratropium with oxygen. If no response, consider IV bolus and/or infusion of salbutamol or even aminophylline. If no response again, consider inhalation anesthesia. For circulation, give further fluid boluses and titrate according to the response. For children, we give 10 mL per kg per bolus. Remember to use glucose-free crystalloids, for example, the 0.9% sodium chloride. Then place an arterial cannula for continuous BP monitoring. Then establish central venous access for easier infusion of the adrenaline infusion. If refractory to adrenaline infusion, consider adding a second vasopressor in addition to the adrenaline infusion. For example, noradrenaline, vasopressin, or metaraminol. For patients on beta blockers, consider glucagon. This is because beta blockers can reduce the effectiveness of epinephrine, which is the primary treatment of anaphylaxis, by blocking the beta adrenergic receptors. And this can lead to inadequate bronchodilation and vasoconstriction, making it difficult to manage anaphylactic symptoms. If the patient is in cardiac arrest, follow the advanced life support algorithm. Start chest compressions early. For newborns, use the ratio of 3:1, and for the big child, 15:2. Use IV or IO adrenaline bolus from the cardiac arrest protocol, which is usually 10 micrograms per kg in children. Then give aggressive fluid resuscitation. Then consider prolonged CPR or even extracorporeal cardiopulmonary resuscitation. Thank you for watching. See you in the next video.